A warm welcome to one and all. This is Dr. Sunil Manuel, Associate Professor from the Department of Orthopedics, and the topic given to me is about tuberculosis of the spine. So what I've done is I've also sent an attachment of a PowerPoint presentation, and I have labeled the slides. So basically, what you need to do is, as I'm moving through the slides with my explanations, I would want you to follow me having the PowerPoint open. So we'll start the discussion with slide number 2. So I have labeled this slide as osteo-articular tuberculosis. So by osteo-articular tuberculosis, what I mean is tuberculosis affecting the bones and joints. So that is the disease burden for an orthopedic surgeon. And osteo-articular tuberculosis is also a extrapulmonary kind of tuberculosis. That is, it is not a primary tuberculosis, it's a secondary tuberculosis. So osteoarticular tuberculosis accounts for around 2 to 3% of all cases of tuberculosis. In osteoarticular tuberculosis, that is tuberculosis affecting the bones and joints, the spine is involved in 30 to 50% of the cases. So TB spine is the most common type of osteoarticular tuberculosis. And let me clarify what I mean by tuberculosis of the spine. So tuberculosis of the spine, when I say, it's not about tuberculosis involving the spinal cord. Neither am I talking about tuberculosis involving the meninges. What I'm talking about is tuberculosis involving the bones that are forming part of the spine. So, or in other words, tuberculosis of the vertebra and tuberculosis of the intervertebral discs. So this condition secondarily can cause damage to the spinal cord. That is because the vertebra is intimately connected with the spinal cord and with the meninges, and definitely any infection or any affection of the vertebra can definitely cause secondary involvement of the spinal cord. So TB spine means infection of the bony architecture of the vertebra. Apart from spine, we also see second most common area for tuberculosis is the hip, followed by the knee, foot, elbow, hand, and shoulder. So coming back to tuberculosis of the spine, luckily for us, we see that this condition is not so common in children. However, when children are affected, the most common site of affection is the upper thoracic spine, typically between T3 and T8. But when adults are affected, which are more common, it is in the thoraco-lumbar spine junction. So what is a thoraco-lumbar spine junction? I'll explain that later. In the adults, it involves mainly in the second to the fourth decade. So which is also the most productive decade. So therefore, TB as a disease becomes a big burden on society. Now we'll move to the slide number 3. So I've put a picture of a thoraco-lumbar spine here. And basically what I want you to understand is this is thoraco-lumbar spine does not mean thoracic spine plus lumbar spine. By thoraco-lumbar spine, what do we mean is, we mean the junction between the thoracic spine and the lumbar spine. And it is clearly defined. It is defined as T11 vertebra, T12 vertebra and L1 vertebra along with the 2 intervertebral discs. So that is what we mean as thoraco-lumbar spine. So whenever we use the word thoraco-lumbar spine, we mean T11, T12, L1 along with the 2 intervertebral discs. Now, there are many theories proposed for why thoraco-lumbar spine is more commonly involved in tuberculosis. Most of these theories are as we say, they're just theories and do not accurately tell us why this happens. But some of the characteristic features of the thoraco-lumbar spine are mainly it's a transition zone between an immobile spine to a mobile spine. So basically what we have is, if we take the cervical spine onwards, coming down to the thoracic, to the lumbar, to the sacral, we see that the cervical spine has got a lot of mobility. But when it comes to thoracic spine, there is absolutely a very less mobility because it's intimately connected with the ribs and it's part of the thoracic cage. Again, now we come from there, when we come to the lumbar spine, we see that there is a fairly good amount of mobility. And then as we move to the sacral spine, we lose the mobility because the sacral spine is again part of the pelvic ring. Now at this stage, we understand that when we come from cervical to sacral, there is mobility followed by immobility, followed by mobility, followed by immobility. So in the same way, this thoraco-lumbar spine junction is the junction of immobility with mobility. So the junction between thoracic spine, which is immobile, now suddenly becoming a mobile spine. It's also the junction where there is a high biomechanical changes, and there is a lot of biological stresses. The other thing that is proposed is that this thoracolumbar spine junction, the bones have high density of spongy bone that are cancellous bone that makes it more susceptible to infection. That is just a proposal. And one more other thing that is proposed is the close proximity of the thoracic duct, the origin of the thoracic duct to the thoracolumbar spine junction. So what we see, the structure called cisterna, which collects all the lymphatics from the entire abdomen, uh, sits almost plastered to the L1 vertebra. So that makes it at higher risk for infection because it is collecting it is part of the lymphatic supply. All said and done, what we need to understand is the tuberculosis of the spine is a hematogenous infection. So the infection comes to the spine through the hematogenous route. Now, what is the importance of this thoracolumbar spine junction? The importance is as put in slide number 5. So if you go to slide number 5, you will realize that I put a picture where the lumbar segments of the spinal cord are marked in yellow and the sacral segments of the spinal cord are marked in green. And you can see that there's an intimate connection between T11, T12 and L1 because the spinal cord ends at L1. And beyond L1, what we have is the nerve roots or the chorda equina. But we are beyond L1, if we have a damage to the spinal cord, that is L2 onwards, if we have a damage to the vertebra, the secondary damage is not going to be on the spinal cord substance. But T11, T12, and L1 are intimately related to the lumbar segments as well as to the sacral segments. And this lumbar and sacral segments are the ones that are giving the entire motor power, the sensory supply to the lower limb. So the motor power and the sensory supply to the lower limb is purely from the lumbar and sacral vertebra, so sacral segments, along with the innervation to the sphincters. So if there's any involvement of the sacral vertebra, sacral segments, you will also have a severe involvement of the sphincters, which can lead to urinary and fecal incontinence. So this is where you should understand that if not identified and treated at the right time, tuberculosis of the spine can be a huge disease burden on the society, because most of these patients can end up in neurological deficits, which will actually change the quality of life. Moving on to slide number 6. So I've made an attempt to make you understand the pathogenesis of tuberculosis of the spine. So the first thing that we need to understand is the infection spreads through the hematogenous spread. So because we are not primary, bone is not a primary structure for involvement of with tuberculosis. So we have this primary foci in the lungs, most commonly in the lungs, to a small extent in the lymph nodes, and to a small extent in the abdomen. So the lungs, lymph node, and abdomen become the primary foci of tuberculosis. From there, usually the infection is dormant. So, but during times of malnutrition, during times of immunodeficiency, like in HIV, or during times when the general immune response is suppressed, like in comorbid conditions like diabetes, we see that these bacteria can get activated, and they can travel through the bloodstream to any part of the body except hair and nails. So any part of the body can be infected through the hematogenous spread. And that is why the parts of the body other than lungs is called the extrapulmonary tuberculosis, and therefore bone tuberculosis is also a type of extrapulmonary tuberculosis. Here, amongst all the risk factors, the most important risk factor is malnutrition. So during times of very bad malnutrition, we see that people can throw up secondary tuberculosis. And the primary pathology in this secondary tuberculosis is in bone is end arthritis. So basically, you can I've put a picture where by trying to make you understand what is a vascular segment. So in the vertebra, basically you have a single epiphyseal artery that will come and divide into two branches. So the one branch will give supply to the lower part of the vertebra above, and the other branch will give supply to the upper part of the vertebra below. So with this, they become one vascular segment. This has got something to do with the embryology of the spine. Therefore, once they become that one vascular segment, the type of affection that we see in tuberculosis would be the lower half of one vertebra and the upper half of the contiguous or the next vertebra. So that is going to be how it is affected, and this is explained by the vascular supply of the epiphyseal artery. Now moving on to the slide number 7. So this is a very nice picture which shows you how a contiguous vertebra is involved. So basically you're seeing definitely there are some color changes in the lower half of the vertebra on top, which I've marked with an arrow, and the upper half of the vertebra of the contiguous vertebra. Along with that, if you compare the intervertebral disc, now moving on to slide number 8, if you look at the intervertebral disc, you can definitely see some change in color as compared to the intervertebral disc at the higher level. So what it means is that basically what we are having is the intervertebral disc is avascular. So primarily it is not involved with tuberculosis, but it gets all its nutrition by diffusion of nutrients into the intervertebral disc from the end plates of the vertebra. So the one intervertebral disc has two sources. One, it gets from the end plate of the vertebra above, and it also gets some nutrition from the end plate of the vertebra below. Now this intervertebral disc is basically now starved of nutrition, and now this intervertebral disc starts desiccating and starts collapsing. So that is the primary pathology. Now if we move to slide number 9, so whatever I showed you in slide number 8, the same thing is happening in the X-ray. Clearly you can see that the intervertebral disc, now this space, all this time I was talking about intervertebral disc. Now what we have in the first picture that I've labeled as early stage, I'm showing you that the intervertebral disc space is now narrowed. That means there is a something happening at the intervertebral disc space, along with increased density of the bone, both above and both below the intervertebral disc. But if you allow this to progress without the disease being identified at this stage, it's only a matter of time before the end plate gets eroded and the entire intervertebral disc is eaten up by the infection. Once the entire intervertebral disc is eaten up by the infection, then you will see a massive collapse of the vertebra, and the vertebra will collapse one on each other. So if you move to the next picture in the late, which I marked as late stage, it is a collapse of two different vertebra, and we can't even make out where the intervertebral disc is. So this is what happens in late stage of tuberculosis, and this is the pathogenesis. Moving to slide number 10. So basically here, once the vertebra is eaten up by the infection, then the vertebra has no choice but to collapse. And this collapse will result in a secondary compression on the spinal cord. Now, what I have marked in yellow, that area, if you notice, is two vertebrae. There were two vertebral bodies sitting there, but they have been collapsed so badly that you can't even identify the remnants of anything. And what I've marked in the black arrow is the thickness of the spinal cord. And what I've marked in the white arrow, you can see that the spinal cord is completely compressed and it's literally plastered to the back of the spine. So this is what happens. This is one way of spinal cord involvement. Another way of spinal cord involvement is there need not be so much of collapse from the tuberculosis, but you can have the purulent material, that is the cold abscess, or you can have the granulation tissue that is coming out from this infection, which can start pressing on the spinal cord. And so you can have that is involvement of the spinal cord, both because of collapse of the vertebra as well as because of granulation tissue that is pressing on the spinal cord. So this is how the disease progresses. Moving on to slide number 11. If this happens at the most common area for tuberculosis, that is T11, T12, and L1. You can imagine the devastating complications that will occur to the spinal cord. The entire lumbar segments and the entire sacral segments are going to be involved. So moving on to slide number 12. So what I explained till now was a typical feature of the most common type of tuberculosis, that is the paradiscal type of tuberculosis. So what I've labeled as one is paradiscal. You can clearly see that the paradiscal is on either side of the intervertebral disc. So because it is near to the intervertebral disc, it is called the paradiscal type of involvement. And the other type of vertebral lesion is a central lesion. Central lesion is more common in children, and here the mode of spread of tuberculosis is proposed to be through the Bateson's plexus of vessels. We also have something called an anterior type of tuberculosis. Now, before that, I just pause and get back to slide number. Uh, yeah, slide number 7. So, if you can just get back to slide number 7. What I explained before was the hallmark of tuberculosis. I didn't tell about that. The hallmark of tuberculosis is involvement of two contiguous vertebra. So when you have a lesion, when an X-ray is presented to you with two contiguous vertebra that are involved, then you should think of this as being from tuberculosis. So two continuous vertebra that are involved, and the intervertebral disc either collapsed or completely damaged. So again, all of this is mainly pointing to the paradiscal type of tuberculosis. Now let's get back to slide number 12. So one other important thing about this picture is this is the most important picture that you will have to, as students, draw in the exam to show the types of vertebral lesions. So I explained paradiscal, explained central. Now moving on to anterior type of tuberculosis, here the infection is anterior to the body, but it is contained by the anterior longitudinal ligament. But the characteristic feature of this infection is it can spread proximally and distally across multiple vertebrae. Though thankfully it is quite rare. Coming to the posterior or appendicular type of tuberculosis is where tuberculosis involves the posterior appendages of the vertebral body, and the articular type of tuberculosis is where tuberculosis involves the facet joints of the vertebra. So irrespective of what kind of vertebral lesion, and especially when you get a patient in a very late stage, it is very difficult to differentiate whether it was a central origin or a paradiscal origin, and these kinds of differentiation make a difference initially in classifying the disease, but they're not going to make a difference as far as the end neurological symptoms is concerned or end treatment is concerned. Moving on to slide number 13, the symptoms are self-explanatory. So you're going to have a patient with severe back pain. One important feature of tuberculosis is a condition called night cries. So basically what happens is, like, the patient goes to sleep, and once the patient normally when the patient is awake, because of affection of tuberculosis, there is a severe muscle spasm, and this muscle spasm helps in keeping the involved vertebra or the involved bone from touching each other, especially when there is destruction of the intervertebral disc. Once the intervertebral disc is damaged, then you should understand that the raw vertebra of the raw vertebra proximally comes in contact with the raw vertebra distally, and that's an extremely painful condition. Now these vertebrae are kept slightly apart because of muscle spasm. That is when the patient is awake. Now when the patient goes to sleep, basically what happens is that the normal muscle spasm disappears, and then suddenly the patient is going to wake up in a sleep and experience severe amount of pain. And this is very very typical of tuberculosis, both in the spine as well as in the hip, and to a good extent even in the knee also. So night cries is one thing that we commonly ask for. Then you have all the general features of tuberculosis: lack of appetite, loss of weight, and things like that. A patient can present with varying degree of neurological deficits, from clumsiness or difficulty while walking to severe paraplegia. And sometimes the patients can present with some features of psoas abscess. The most common feature that we see of psoas abscess is back pain again, and or abdominal pain. very difficult to identify this clinically, psoas abscess, unless it is pointing out from somewhere. So some common areas where it points out is along the iliac crest. So there it can just point out. It will be a fluctuant swelling. If it is pointing from there, clinically we can make out. Or it can also sometimes go down through the inguinal ligament and point through the femoral canal. So there what happens is it may mimic something like a femoral hernia. So these are the symptoms. Moving on to slide number 14. So the most common sign that we get in a patient with tuberculosis is spinal tenderness, both tenderness of the spine as well as severe paraspinal tenderness. That is what we get. And the characteristic feature here is paraspinal spasm. So a very commonly done test is something called a coin test. So basically what we do is we drop a coin, or we can drop anything that you want onto the ground and tell the patient to bend and pick it. So what the patient does is that typically the patient will bend his knee. He will not bend his spine. So that will clearly give us an indication of severe paraspinal spasm. Of course, this coin test can be positive also in other conditions of the back, that is in intervertebral disc prolapse also, when it's causing severe paraspinal spasm. Moving on to slide number 15. Okay, here is a picture of a kyphosis or a gibbous. This kyphosis or gibbous is the result of collapse of the vertebra. And this kyphosis or gibbous is something that we should be able to clearly identify with a clinical examination. And sometimes it can, or the patient can present with severe kyphosis, in which case, as you move to slide number 16, you see these are very old pictures of patients with severe gibbous, severe kyphosis. Now moving on to slide number 17. So what are the investigations you will do? So the X-ray is self-explanatory. Anybody who is going to come with symptoms like this, we are going to get an X-ray. So I'm not going to show you any X-ray pictures because I've already showed you before the early tuberculosis involvement and the late tuberculosis involvement X-rays. But I'll just give you one or two important points. That is, the first feature of tuberculosis of the spine is narrowing of the disc spaces on an X-ray. Now, what you should understand is that this is different. This question, that the answer to this question is different from which is the first area of involvement of tuberculosis of the spine. The first area of involvement of tuberculosis of the spine is the vertebral body. But the first sign on X-ray in a tuberculosis is narrowing of the disc space. Why this happens is because though the body is involved, it takes something like 3 to 6 months for the bone to show the changes. So relying on X-ray could be very futile. Second important thing is this narrowing of the disc space also can be commonly seen in intervertebral disc degeneration. So it is very difficult at that stage to differentiate it from tuberculosis unless we also have serial X-rays which shows over a period of time the intervertebral disc collapsing, or we have severe involvement of the body. So relying on X-ray to make a diagnosis of tuberculosis, though it's the cheapest available modality, especially in the early phase, could be quite tricky. And therefore, we have to have a high index of suspicion and think of other investigations. I'll come to that later. The other thing is the characteristic feature of tuberculosis is, as I mentioned, collapse of the disc with contiguous vertebral body involvement. That is the characteristic features. Occasionally, you can have something called skip lesions, where you will have TB lesions in two vertebrae, and above in some other vertebral segment, or below in some other vertebral segment, you may have a secondary another lesion of tuberculosis. That's called a skip lesion, but that's quite rare. And this is what I emphasized about bony lesions taking 3 to 6 months for them to appear on X-ray. But X-ray is very, very useful for monitoring treatment to therapy. So once you start treating the patient, you want to look for some signs. So those signs are very clearly visible on X-ray. I'll come to that later. And the most important thing is anybody in whom we make a diagnosis of tuberculosis of the spine, we have to 100% get a chest X-ray and a HIV testing. Both 100%. Why? Because tuberculosis of the spine or any tuberculosis in the body could be an indicator that the patient could be having pulmonary tuberculosis. That is point number one. Point number two is the fact that the patient has tuberculosis could be an indicator that the patient could be having some kind of immunodeficiency, and it could be the one point checkpoint at which we may be able to detect HIV. So as per the law of the land, as per the law of India, it's mandatory that an orthopedic surgeon or a doctor or any doctor who is making a diagnosis of extrapulmonary tuberculosis should have a chest X-ray, as well as should be able to convince the patient and get a HIV testing done. So no offense on the patient. Moving on to MRI, MRI is the investigation of choice. If we can move to slide number 18, MRI will clearly show us the level of vertebral involvement and the level of intervertebral disc involvement. It will also show us how much of pressure is there on the spinal cord. None of this information we would have got from the X-ray. In fact, if in slide number 18 you see this MRI of this patient would have had literally a normal X-ray with a little bit of narrowing of the intervertebral disc if you are doing his X-ray. Of course, because there is a good amount of pressure on the spinal cord, if you were not careful, you would have even missed the neurological deficit. So this is where MRI is of paramount importance. So any index of suspicion, anything that suggests towards tuberculosis, anything that suggests an infection, always try to convince the patient for an MRI scan. Moving on to slide number 19, clearly shows a picture of how a psoas abscess looks. So basically, what is the connection of the psoas abscess to tuberculosis of the spine? The psoas muscle that we know takes its origin from the vertebral bodies, and therefore, when there is tuberculosis involvement, the psoas muscle has got a beautiful sheath around it. The sheath is something like a plastic cover or like your bag, college bag. So whatever pus that starts getting generated in the vertebra finds it very easy to move along the sheath of the psoas muscle. It doesn't move on top of the psoas muscle. It moves in between the sheath of the psoas muscle. So beautifully you can delineate the psoas abscess based on the its involvement along the line of the psoas muscle. So what is marked in white is the psoas abscess, and what is marked in red is the normal psoas muscle. Moving on to slide number 20. So here we have, at this stage, we need some tissue diagnosis. So the way to get the tissue out of the body is, because tuberculosis, again, now if it's involving the spine, doing an open biopsy and getting it may not be required in all patients. Getting the tissue may not be required in all patients. So these days what we are doing is, we are doing a CT guided biopsy. So once we have an MRI or once we have an X-ray that is suggestive of tuberculosis, then we ask for a CT guided biopsy where the radiologist and the pathologist together, they'll be able to go exactly to the lesion and take out a biopsy. If the CT guided biopsy is not possible, or we are not able to do it, then open biopsy is one choice. And open biopsy is most commonly done when the patient is taken up for surgery for tuberculosis, of the vertebra. And sometimes we do an open biopsy in patients in whom we have a strong doubt that it's tuberculosis. So to confirm our doubts, we'll have to do an open biopsy, and the biopsy will be reported by a pathologist. Moving on to slide number 21. So microbiology. So direct microscopy using AFB, very difficult direct microscopy for AFB, acid fast bacilli, very difficult in the pus or the granulation tissue. In fact, extrapulmonary tuberculosis, the amount of getting direct bacteria in the pus is is almost, you can say, impossible. But then culture could be quite useful. The only disadvantage of culture is that you will get the culture reports only after 2 to 3 weeks minimum. The other testing that we send patients samples is for a testing called TB PCR, which will give us the report within 24 hours. So that's a very useful test. Also, it's mandatory by the government now to send all samples wherever we get the sample to be sent for CVNAT testing. So it's a primary kind of testing that the government is doing for to check for drug resistance. So our job is to, wherever we take out a biopsy, wherever we take out a CT guided or an open biopsy or some tissue, or when we drain the Psoas abscess, what we do is some of it, apart from going to the pathologist and our microbiology lab, will also be going to the CVNAT testing. And this CVNAT testing will not be done in our hospital. It will done in regional centers. So it will go to those places. And as I mentioned, testing for HIV is mandatory. Moving on to slide number 22. So let's take a look at how we can treat this condition. Now, one important thing that I want to emphasize very clearly is, even now our country has got a very high load of tuberculosis. And as I mentioned, 2 to 3% of tuberculosis patients have bone and joint involvement. Out of them, 50% of them have spinal involvement. So the disease burden on the nation is quite high. So what I want you to understand, that the core principle or the core takeaway from this class is, not everybody with tuberculosis requires surgical management. That is the one thing. And if you can take this message clearly, I think I would have my class should be quite a success. So the cornerstone of medical management is most important, ATT and good nutrition, both of which can be instituted at home. And patient also will be very comfortable to be in their own houses and take the treatment. One important thing that the physicians have to do, or the treating doctors have to do, is, we are now tuberculosis is a notifiable condition. So before starting the patient on ATT, there is a small form that's available in all hospitals. We have to fill up the form with the patient's details and send it to the government. So it's a notifiable condition, so that the government also understands and knows what is the disease burden in the society. Second important thing is, there are some changes to ATT regimen, and whatever I'm telling now uh, is as of 2020. So first of all, ATT is now given as a fixed dose combination. Previously, it was different drugs with different capsules. Now everything is put into the same tablet, all the drugs. And the other thing is that tablets are given strictly according to body weight. So those calculations are made. And for a detailed description of the body weight, what is the dose of drugs and all, I would request you to refer the textbook part from community medicine, where there's a clear tabular column in which they've given the doses for each body weight category. Uh, and these days we do give the daily regimen. So we have moved from giving alternate day regimen to daily regimen. So the patient has to take the tablets every day, and the treatment schedule is different from what it is for pulmonary tuberculosis. So pulmonary tuberculosis, it's for 6 months. But here the minimum treatment for bone and joint TB, and this is true for all the tuberculosis of the bone and joint, that is tuberculosis of hip, knee, whichever part of the body you get, it would be for 12 months, a minimum of 12 months, in which the first 2 months is the intensive phase. You'll be giving all the 4 drugs, HRZT, and the next 10 months would be the continuation phase. At the end of 12 months, the treating physician will do some tests to determine if the patient is cured. And after he determines that, then he will certify the patient as cured. If there is any index of suspicion, or if the physician is not happy, he can extend the regimen up to 18 months. So the 18 months extension is also only the continuation phase, that is HRE. Moving on to slide number 23. So when the patient is being put on this treatment, so it's a very dangerous condition, tuberculosis of the spine. But as you can see, the patient is just given ATT and told to have good food. That's it. And so, but then that's not the physician's point of view. What the physician has to do is, he has to monitor the treatment. And this monitoring does not mean that the patient has to be admitted. The physician can frequently see the patient. Initially, personally, I would like to see a patient whom I put him on ATT for at least once in a fortnight for the first 2 months. After that, I would want to see him every month. So the patient, the first thing that I'm looking for is drug compliance. This is the biggest worry that we have, because the patient's symptoms, back pain, paraspinal spasm, and so to a good extent even neurological deficits, everything just disappears at the end of 3 to 4 weeks of treatment. And after that, to convince this person to have the drug for 12 months is the most difficult thing to do. So this is where monitoring, frequent interaction, frequently calling the patient helps. Second important thing that we are looking for is drug intolerance. So if there is intolerance to drugs, then there's a totally different regimen for that. What we do is, when there is an intolerance, we refer the patient either to the pediatrician or to the general physicians who institute the regimen of the other drugs, which could sometimes be more more toxic than the primary drugs, first line drugs. The other thing that we are looking for is, we want to see whether there is any clinical improvement or clinical worsening. Now, this clinical improvement, as I mentioned to you, will be noticed by the fact that the patient feels much better, his appetite improves, he starts gaining weight, and he also reports that the pain and the paraspinal spasm and the discomfort, everything is going off. That's a very good sign. By worsening, what I mean is worsening of any neurological symptoms, or the patient showing no improvement at the end of 4 weeks. Now, we need not jump the gun on X-rays, because X-rays can wait. We need to mainly see the patient clinically. So personally, we do X-rays once in every 2 months. And one important thing that we should understand, that radiologically, the cure of tuberculosis lacks the clinical cure. What do I mean by that? Once again, I'll just repeat the sentence. The radiological cure of tuberculosis lacks, LAGS, lacks the clinical cure. So that means the patient clinically will be much better, much earlier. But for us as doctors to see it on an X-ray, it takes some more time. So maybe my healing process, or my, good signs on X-ray will be seen only around 6 to 8 months. But the patient at the end of 1 month itself will start getting better. And this is true for all types of osteoarticular tuberculosis. So that's an important clinical pearl. So if the patient does not have any neurological deficit, that doesn't mean that he will not have any neurological deficit after that. So what we do is, once we know the MRI finding, or once we know the X-ray finding, we allow the patient to mobilize or move around at home minimally, but we also give him a brace that will prevent him from having a collapse of the vertebra. But if there is a neurological deficit, then we institute strict bed rest. In this case, one important thing is, the patient also has to be turned around if there is sensory involvement. So how to turn the patient, all those instructions we give to the family members, and then they can do it at home itself. If the patient shows any improvement, the patient who has a neurological deficit, then he can actually once again get back to mobilization with the braces. And I told you what I call as declaration of cure. So for me to call a patient as declared cure, one, his back pain should have totally disappeared, and on clinical examination there should not be any tenderness in the spine or in the paraspinal muscles. Third important thing I look for is the blood parameters. I look for a falling ESR, and I look for a falling counts. I look for a falling CRP, C-reactive protein also. And radiologically, I'm looking for fusion of the involved bones. So why does this happen? So normally what happens is, we have the intervertebral disc that is sitting in between. So over a period of time, the intervertebral disc desiccates, or the intervertebral disc is eaten up by the infection. And therefore, the raw bone of the vertebra above comes in contact with the raw bone of the vertebra below. So when the raw bones of the vertebra come in contact with each other, they go in for fusion. And with increasing fusion and increasing bone density, I can be sure that the patient is cured. So once I declare the patient as cured, then my further follow-ups with this patient will be once every 6 months for a period of 2 years. Sometimes, and also I give a clear instruction to the patient that in case there is any worsening of the infection, or if there is any new signs coming up, come back immediately. Now moving on to slide number 24. Now these are 3 sentences that every medical student should know. How infections end in bone and joints. Okay, so the first sentence says the end result of a septic arthritis or pyogenic infection. What do I mean by septic arthritis or pyogenic infection? Septic arthritis means infection with bacteria other than tuberculosis. So most commonly it is Staph aureus. So the end result of an septic arthritis or a pyogenic infection is bony ankylosis. In a synovial joint is bony ankylosis. That is fusion of the bone with end-to-end bone connectivity. So this happens in septic arthritis, like in knee septic arthritis, hip septic arthritis, you will have a bony ankylosis. However, if the same joint, if the same synovial joint, like knee and like hip, has a tubercular infection, then the end result is a fibrous ankylosis. That means there will be no bone-to-bone fusion. There is only going to be, there is not going to be much of movements, but it's mainly because of extra-articular fibrosis. The reason for this is because in septic arthritis, within a period of 24 to 48 hours, the entire articular cartilage melts like butter, and therefore the entire articular cartilage is ripped off, and raw bone of either surfaces of the joint come in contact with each other and leads to bony ankylosis. But in tubercular arthritis, tubercular infection of the joints, what basically happens is the tubercular infection does not damage the cartilage as much as it does in septic arthritis. Secondly, even if it starts damaging the cartilage, it starts damaging the cartilage from the periphery of the joint and then slowly moves towards the center. So at some point, we would have identified the condition, we would have started ATT, and therefore the central part of the joint is still maintained. The central part of the joint cartilage is still maintained, which will give him some amount of very, very minimal movement, but will not result in a bony ankylosis. So these two sentences, the first and second sentence, you should know very thoroughly. However, the end result of a tuberculosis of the spine is bony ankylosis. Why is that bony ankylosis? Because I told you what prevents a fusion of the bones here is the intervertebral disc. And once the end plate of the vertebra is eroded, the intervertebral disc will disappear in no time. And therefore, a raw bone of the vertebra on top and raw bone of the vertebra below will come in contact with each other, and that will cause the fusion of the spine. So the end result of TB of the spine is bony ankylosis. The end result of TB anywhere else in the body in synovial joint is fibrous ankylosis. Moving on to slide number 25. So coming to surgery. So no discussion on tuberculosis or no discussion from an orthopedic surgeon should end without telling you about surgery. So the two principal purpose of surgery would be one to establish the diagnosis. Where do you have the doubt? We have the doubt when there is poor response to ATT. We've given ATT 4 weeks, not much response, patients are not improving, but we are very sure it is tuberculosis. So let's go for a surgery. Let's take out some biopsy. So that would be one thing. Second thing is uncertain diagnosis or suspicion of drug resistance if you are suspecting that. So this is for the doctor. The first point is for the doctor to establish diagnosis. The second point is for the patient to treat spinal deformity. So the patient is completely going for a collapse of the vertebra, threatening to cause neurological deficit, or the patient is having instability in the spine, or if the patient is having neurodeficits per se. So in such conditions, we will have to go for surgery. So what is the surgery that we do? What we do is there's a two-step surgery. The step one, what we do is we do something called disease clearance. We decompress the spinal cord by removing all the pus, the granulation tissue, everything, and we clear the bone of also the infection as far as possible. And in step two, we have at the end of step one, we have created a more unstable spine than we began with. So in step two, we have to do something about stabilizing the spine. So in step one, we are removing the disease. In step two, we are stabilizing the spine. And along with that, we are also aiding in the fusion of the spine by either putting a bone graft or we are putting these days we use a titanium cage. So we can put a cage there where the vertebra was sitting. In place of the vertebra, we can put a cage, and we are going to help it to fuse by putting implants from posteriorly. So that is called a posterior instrumentation, and all this surgery will be done under the cover of ATT. That means just like we take up any patient for surgery and we give perioperative antibiotics, similarly here the perioperative antibiotic will be ATT. Whether your diagnosis is confirmed or not, you have to start the patient on ATT and then do this surgery. Later on, if the pathologist comes back and say, no, sir, it's not tuberculosis, it's something else, then we can stop the ATT, no problem. Okay, moving on to slide number 26. Here you can see a picture. On the top, you can see the X-ray and the MRI of the patient who presented. And in the bottom, you are clearly seeing a nice, first they've removed all the diseased bone and they've kept a cage. That cage is kept there to prevent the vertebrae from collapsing. So once the cage is kept also, from posteriorly, the implant is placed to prevent the vertebra from collapsing. So this is going to help us to prevent the collapse of the vertebra, because the collapse of the vertebra can lead to instability in the spine. Now the difference between pyogenic infection and tuberculosis is that in tuberculosis, in spite of having an infection inside, you can still put implants there, and you can continue the patient on ATT. It will work, but the same thing will not work in a pyogenic infection. Now that ends my class on tuberculosis, and I think it's 45 minutes at this stage. But I think I'll just speak a few words about POTS paraplegia, that is tubercular paraplegia. So pardon me for that. Basically what happens is, like, POTS paraplegia or tubercular paraplegia patient could be found in any one of the wards. The patient can either be in the medicine ward or it can be in the orthopedic ward. That's because the patient now has got something called a neurological deficit secondary to an orthopedic problem. So, and he can also be found in the neurological ward. So this is a patient who is now having paraparesis or paraplegia secondary to tuberculosis. So it's the most dreaded complication of tuberculosis. It can occur in 10 to 30% of cases. And again, as I told you, the first 3 decades, mainly in the second to third decade. And highest incidence of paraplegia is seen when the thoracic spine is involved. Why? Because the lumbar spine, I told you, is quite voluminous and it can accommodate. But when thoracic spine is involved, then you have a high chance of POTS paraplegia. Moving on to slide number 28. Generally, it is classified as early onset paraplegia and late onset paraplegia. Early onset paraplegia has got a good prognosis. This is paraplegia that occurs within the first 2 years of diagnosis of tuberculosis or the appearance of tuberculosis. But if the patient comes with paraplegia after 2 years of diagnosis, it's got a bad prognosis. Why? Because the late onset paraplegia is mainly because of scarring, severe scarring in the meninges or severe scarring in the spinal cord area, and not much of surgical help can be done at this stage. But early onset paraplegia definitely will respond very well to surgery. Moving on to slide number 29. This is a clinical staging of the POTS paraplegia, in which case we have to understand that we should reclassify the name as paraparesis or paraplegia. So in stage 1, the patient, it's a very negligible finding. So the patient is very unaware that he's got a neurological deficit, except that when he walks, there is a little clumsiness. But if the physician is sharp, he can detect hypertonia, and he can also detect clonus. So detection of clonus, detection of brisk jerks, brisk deep tendon reflexes is the responsibility of the physician and not the responsibility of the patient to tell that, sir, I'm having weakness in things. That's in stage 1. And if you can identify a patient in stage 1, fantastic. That means you can prevent the patient from going into stage 2. So that is the importance of clinical examination. In stage 2, it's a mild kind of involvement where the patient is aware of deficits, but he can still walk. That's because he's got more than grade 3 power. Grade 3 is anti-gravity muscles. So as long as your anti-gravity muscles are working, you can walk. Stage 3, it is moderate, where the patient becomes paralyzed with power less than grade 3, and there is also sensory deficits of less than 50%. Sensory deficits totally turn the equation against the patient. Why? Because when you have sensory deficit, the problem is there is a high chance of bed sores now, and that can actually kill the patient. In stage 4, the patient has severe muscle spasms, and that itself prevents him from being kept in bed. And these spasms are also painful. The patient can also have sensory deficits more than 50%, or the patient can have involvement of the sphincters. So that is a very severe stage of involvement. So that is stage 4. So now coming back to treatment, once again, let me re-emphasize the stage 1, 2, and 3. You can start the patient on medical treatment itself, in spite of him having neurological deficits, with ATT. and you have to clearly monitor this patient for clinical response. We would prefer to keep the patient in the hospital only because the patient has already come with neurodeficits. So we will reassess the patient at the end of 4 weeks and decide what next to do. If the patient's neurodeficits are improving, then we will continue him back on the same oral treatment and maybe even discharge him. But if the patient's neurodeficits remain the same, or if they are worsening, then we are going to subject this patient for surgery. So that is how the protocol would be. And this is the indications for for surgery in patients with neurological deficits. So as I mentioned, no improvement with treatment of 4 weeks of ATT. Or second thing would recurrence after initial improvement. Initially it shows some improvement, then again recurrence, then worsening of neurodeficits. Like you came up to us in stage the power grade 1 grade, and then the grades of power is worsening. So there's no point in waiting. Straight away we'll go for a surgical treatment. So in surgery, what do? We do disease clearance, and then we stabilize the spine. The other thing is rapid onset of paraplegia. It's a good. It's not a good sign. So we have to take up this patient for surgery and do the disease clearance. And stage 4. If a patient comes with stage 4 of the paraplegia that I mentioned in the previous slide, then you will have to treat this patient with surgery straight away. There is no doubt about that. So with that, I end my class. I think that was quite comprehensive as far as possible. So if you have any doubts, you can always get back to me through your class rep, and I'll see whether I can do one more session and clear your doubts. Thank you.